Good morning, everyone, and this is the first lecture of this semester. And the first two lectures will be about liver. Now, um, about liver, first of all, of course, I will go for introduction and we will briefly discuss the introduction about the liver. So, and in the last century or in the last few years, you can say that there is too much advancement in the medical field that nowadays we see that the patients they can get liver transplantation surgeries and mm, not just liver transplantation but nowadays like complicated surgeries are possible. One thing about liver is what because liver have very extensive blood supply, so it was very hard for the surgeons to perform any kind of surgery on liver. So for all these years, they keep on trying uh, how to arrest the hemorrhage or hepatic hemorrhage or the hemorrhage, the blood coming out from the liver uh, due to anything, most commonly trauma, um, because it's have a very extensive blood supply. So, like many people who are involved in traffic accidents, or what we call it as deceleration injuries, their liver start bleeding, and it's very hard to stop the bleeding. So uh, now in the you can say in the last 100 years or in the last 100 or 200 years, you can say there is too much advancements in the liver surgery. For example, nowadays there are techniques for suturing major hepatic vessels, uh, and cauterization of small vessels. Then when we will go and discuss further, uh, like when we will discuss liver trauma, so there is something called a Springle procedure, which is um, you can say discovered by um, Hogarth Pringle. That's why it is called a Pringle procedure, just to stop the bleeding from the liver. So and many other things are now available, like as a result of what you can say the liver surgeries are quite possible nowadays with lower mortality rates and better outcomes. And nowadays, of course, like as I told you, liver transplantations are going on in this world, and not just these. There are newly uh, discovered minimally invasive approaches to liver surgeries have also been in many parts of the world. Like the doctors or the surgeons, they are using, for example, to deal with the hepatic tumors or liver tumors. Nowadays they are doing something called as microwave ablation or radio frequency ablation, things like this. Anyhow, first of all, I will go for a little introduction, and then what we are going to discuss is all the topics are in front of you. We will be discussing liver trauma, we will be discussing liver carcinoma, uh, and like the primary liver cell carcinoma, because the secondary ones, of course, they are as a result of metastasis, which comes from cancers and or neoplasms, malignant conditions in other parts of the body. For example, the colorectal carcinoma can seed or can metastasize to liver. We will talk uh, a very short discussion about the abscess. We will discuss in the end. So you can say the important thing is, because we are discussing the liver condition from surgical point of view. So uh, of course we should not go towards the medical part. So now the important thing about liver is there are many surgery textbooks. There is Bellis and Love, which I think like all of you know. Then there is other books like Washington Manual of Surgery. There is Sebastian Textbook of Surgery. There is Schwartz Principle of Surgery. So there are many books of surgery which are available, and it depends on you what book you want to study. But anyhow, the important thing here is, which I wanted to discuss, is simply uh, I will talk a little about the introduction. Of course, I will not go in too much detail anatomy. I will not go in too much detail physiology. Of course, like they are going to take a lot of time. And now, uh, liver, you can say it's the largest organ inside the body. Okay, like skin is also an organ, and skin is also big, but liver, in the body, this one is the largest one. And it's like the weight is around 1.5 kilograms, or you can say 1,500 grams. And as all of us we know that the liver is located in the upper right quadrant of the abdomen, and it is well protected by the ribs. So one thing is the gross anatomy, one thing is the microscopic anatomy. So if I will talk about the gross anatomy, uh, liver appears reddish brown in color, and it is held in place by several ligaments. Better to show you this diagrams. Okay, so you can see like there is a round ligament. Okay, and uh, also what you can say, there is a falciform ligament, uh, which is you can see in this one right here. And simply, like, what is the function of these ligaments? For example, this falciparum ligament, uh, it separates the uh, you can say the left lateral and left medial segments. Okay, and it also um, held the liver to the anterior abdominal wall. So now there is a right lobe of the liver. You can see like there is a left lobe of the liver, right? And of course, like you have done the anatomy, so I think like you guys should know better anatomy than me. But what we call it as a surface anatomy. So the thing is that uh, whenever we see the liver, above there is a diaphragm, and down you can see the gallbladder, and of course here there is the abdominal wall, and this one is this area is all uh, comes in connection with the structures inside the abdomen. For example, see, um, uh, this one is gastric depression. Okay, and you'll find like renal impression. Of course, like this part comes in contact with what you can say the kidney. Okay, so anyhow, the important point is that like this is what we are discussing is the gross anatomy. And what happens is like as you can see over here, the liver is divided into the right and the left lobe. Okay, there is something called as functional segments or functional anatomy. Okay, so uh, there is something called as cantile line, um, like you can see over here maybe. Okay, cantile line, like if you will see any anatomy atlas, or you can see any photograph of liver anatomy, you would see that the liver, uh, the right and the left lobes, okay, they are separated from the gallbladder fossa uh, to the inferior vena cava, which is known as Kently's line. So the right lobe is much bigger, right? And it is around the 60 to 70% of the liver mass. and the left lobe, something called as caudate lobe, is also there. So this is the caudate lobe. So the caudate lobe and the left lobe is the remaining, you can say, the remaining 30 to 40% of the liver. Now, the important thing over here is like functionally, uh, liver can be divided into these segments, okay? And basically, there are 8 segments, which you can see, okay? 1, 2, 3, 4, 5, 6, 7, and 8, okay? So, functionally, liver can be divided into 8 segments, and simply, what is the function of these 8 segments, or why they divide do this functional division, like for surgical purposes? Because it's easy to perform surgery. Each segment have its own, you can say, dedicated vessels or ducts, to supply that region. You can see over here, okay? And see this one. Ken Kleiss first described the lobar anatomy in 1898. Okay, so he's the one who did this. So you can see the numbering of the segments over here, right? And see, this one is like what I was talking about, the round ligament. This one is like the remnant of the umbilical vein, by the way. That's why they write in the bracket umbilical vein. So in the fetus, there was umbilical vein, so this round ligament is formed as a remnant of that, or you can say the left behinds of that thing. So okay, so simply, this is like the functional. This is called as a functional division, right? Now, the important part over here is that liver have a dual blood supply. It comes from the hepatic artery. Okay, you can see over here. They mark over here, or you can see this diagram again. Like the hepatic artery is there, right? And it also get the blood supply from the portal vein. So portal vein is the one which is bringing blood from all the GIT. So the hepatic artery supplies around 20 to 25% of the blood supply, whereas the portal vein supplies the rest of the blood. And uh, there is a common hepatic artery which is further divided into the gastroduodenal artery and the hepatic artery proper. So now the thing here is, um, whatever book you will read, by the way, they are talking about these blood supplies, in the start of that thing. So now the thing is that uh, in the books you will find that there are a lot of variants, variation. It's not like this, like all the people they have like the same arteries, you can say. Okay, like first, sometimes you can say the hepatic artery is replaced by some other artery, like for example, it may arise from superior mesenteric artery. Okay, so anyhow, we are not here to talk about those variations, because we are not here to talk about too much anatomy. So as I told you, the portal vein, it comes from the uh, it is bringing the blood from the GIT. Okay, and now like all the GIT blood, it is brought to the liver by the help of portal vein, and it is formed by a combination of different veins, mesenteric veins and all this stuff. So now, like really, I don't know how much well you know about the things which I'm talking about, but simply, uh, this is like the two sources of the blood supply, which is here, right? Now, the hepatic veins, okay, which is on the top, you can see over here. There is right, left, and middle. Okay. Now they drain the blood to inferior vena cava, and inferior vena cava, as we know, like it is going to drain into the right atrium, right? So the thing is, like, simply the point here to be noted is, like, all the blood from GIT is going to pass through the liver, and ultimately it is going to drain into the inferior vena cava, which will uh, go to the right atrium, right? So now you can see over here, this is about the lobes. This is like the surgical anatomy of the liver, and see, this is the inferior vena cava, and this one is the right hepatic vein, the middle hepatic vein, and the left hepatic vein. And whereas this is the portal vein, this is the hepatic artery. Okay, so uh, like this is how it looks like, and this is again like they're talking about the functional anatomy. So like, for surgical purposes, because, for example, if someone have to resect the liver due to, for example, there's trauma and this part of the liver is bleeding too much, so they are going to cut it off, right? So they are going to cut these two segments. Or someone who wanted a liver transplantation, he want to donate his liver, so of course, like, they take the functional units of the liver. One good thing, the liver regenerates by itself. This is a very, very, very important piece of information, which what you can say, which is very good, and that's why liver transplantation, after giving liver, the liver has the capacity or the ability to regenerate. Okay, so that's a good thing. So after that, if we will talk about the next part, or the next thing, which is what you can say. Uh, okay, I explain all these things. I talk about these things, right? So, and the SIG as well, and this one as well, right? So the point here is to discuss the further things which we can discuss over here is about the biliary tract. Okay, so going back to this one, um, the important thing here is, like, the liver makes bile, right? And there is a gallbladder attached to that, and the cystic duct is the one uh, which is connected to the gallbladder. Okay, and then it uh, what you can say, it combines with the common hepatic duct. Okay, so simply, um, these ducts basically, you can see, like, the common bile duct over here, and the gallbladder is over here, and they basically follow, um, you can say, like this one. Okay, like they basically follow the blood supply of the liver. Okay, so simply you can say it like the hepatic ducts follow the arterial branching pattern inside the liver, so that's why each duct is going to enter into each functional unit. So now there's a lot of variations in this bile duct or the biliary tract also. Okay, so the parasympathetic innervation of the liver comes from the left vagus. Okay, and the lymph, which is produced in the liver, they are drained by perisinusoidal space of Deci, and that drain into the cystic duct lymph node, and we call it as Callet's triangular node. Okay, so now uh, the important thing over here is, like, of course, like, maybe it's taking a lot of time, I'm talking about anatomy. I'm not talking about too much details. I'm talking really, can say superficially. But the thing is that if you will study uh, the liver anatomy in detail, of course, there is a lot of details of the anatomy, right? And same thing with physiology. Like we know what are the functions of the liver, right? We know what is cirrhosis because you have done those things in internal medicine, and when you have done those things in internal medicine, so you must know uh, what is cirrhosis, what is acute liver injury, what is chronic liver injury or chronic liver disease, okay? And people like what we call it as liver failure. Of course, like in surgery, we are not going to discuss jaundice and all this stuff, right? We can discuss jaundice, which are related with uh, surgical causes like liver carcinoma, pancreatic carcinoma, things like this, right? So, talking about the physiology of the liver, liver is called as you can say, the metabolism headquarter of the body, right? And it is performing many critical functions, like metabolism is one of them, energy metabolism, right? It is a one which is forming or making, synthesizing large number of proteins, large number of enzymes, vitamins. It is the one which is detoxifying the drugs, not just the drugs, rather you can say both exogenous and endogenous substances. So you can say like liver is a filter in the human body, right? So uh, like of course, and one of the function is bile formation as well. And like what is the function of the bile? Okay, what bile is doing? Bile is the one which is helping in the absorption of all the what you can say the fats, right? It causes it does emulsification of fats. So and that's why someone who in which like the biles are not there, so they cannot um, you can say digest the fat soluble vitamins A, D, E, K, and then we have to provide them, right? So approximately you can say 1500 ml of bile is secreted daily, and for example, this bile flow sometimes when it is blocked, we call that condition as cholestasis, right? So bile formation is one of the function. Uh, it also metabolizes bilirubin. Okay, of course, it is the one which is doing all the metabolism. No matter it's uh, carbohydrates metabolism, glycogen storage, and all these things. Okay, it's lipid metabolism, it's protein metabolism, and liver is you can say the hub which is synthesizing the proteins, catabolism of proteins, any excess amino acids and nitrogen waste. So liver is the one which is managing all that. Okay. Also, it is forming the clotting factors. Of course, they are proteins. So that's the reason. If you will recall your liver topics from internal medicine point of view, you would know like whenever we go for liver function test, they give us the bilirubin level, both direct and indirect. They gave us the ALT and AST, GGT, gamma glutamyl transferase, alkaline phosphatase, and all those things, right? And also we can go for the clotting profile, and they also give us how much is the albumin level in the body, because liver is the one which is making up the proteins. So okay, so now uh, of course we are not going to discuss the uh,
medical topics, or you can say internal medicine topics over here, right? Rather, we must move on what you can say the surgery, the surgical topics, right? So, what kind of tests we do, by the way, whenever we have to discuss about the liver, like there is liver function test which we can do, right? One of the thing is liver functions test, LFTs, right? And we order this thing, okay. Other than that, there are different causes of liver conditions. For example, hepatitis is very common. Drugs can cause hepatitis. Paracetamol can damage liver. Different type of poisons can damage liver. Certain inborn errors of metabolism like Wilson's disease, hemochromatosis, they can damage the liver, right? And ultimately, all these things can lead to chronic liver diseases like uh, anyone who have chronic liver diseases, like a few days back, in the class I was talking about, whenever you go for the abdominal examination, so in the abdomen there is liver, so we check the BMI of the patient. We check either they are jaundice, we check either they have Palmer erythema, we check either they have enlarged parotids, we check either they have gynecomastia, we check either their hair distribution on the chest is normal or not. We check either there is spider nevi. Uh, okay, so all the things I see, or okay, also we check or we see the patient if there is any petechias or ecchymosis. So what we are doing, by the way, we are just looking at the liver functions, and anyone in which like these are compromised, maybe the patient is having ascites, maybe the patient have lethargy, maybe the patient is weak, maybe the patient have jaundice, maybe the patient have Palmer erythema, maybe the patient have leukonychia. Okay, so maybe the patient have hepatic encephalopathy. Okay, in which like there will be slow slurred speech, uh, they appear confused, they have memory impairments and all those things, right? Maybe they have hepatic flaps, or you can say like the hepatic tremors, right? Which are also called as flapping tremors. Uh, Maybe you will find ascites, maybe you will find bruising of the skin, or you can say petechia and ecchymosis. It means like the liver is not functioning normally, right? So simply like this is what I'm talking about is like what happens when the liver is damaged, right? The other investigations which we can do in the liver, or you can say to check the structure of the liver, we can go for ultrasonography. Okay, so ultrasonography is very, very, very important investigations because it can catch number of things like gallstones, uh, and it can catch some cancers, or you can say the tumors. We can go for CT scan, computerized tomography, and of course, like it can catch. Like these are the tests of the structures, not the functions. Liver function tests are different, and liver structural tests are different, right? So of course, like the CT scan can catch a lot of things, right? Tumors it can catch. It can catch any anomalies in the vascular pattern, for example. We can go for MRI, magnetic resonance imaging. We can do something called as ERCP, or endoscopic retrograde cholangio pancreatography. So like this one ERCP, it's like of course it's endoscopic, retrograde like going in opposite direction. So okay, ERCP, uh, is basically done to for the patients who have obstructive jaundice. I'm sure like you have covered this topic, right, in internal medicine, because internal medicine is complete. So
And remember one thing, that ERCP is only required when the patients, they cannot undergo MRCP, which is magnetic resonance cholangiopancreatography. Okay, so that's the only indication we can go for ERCP, because nowadays we go for MRCP, right? So sometimes, um, ERCP is done to remove the stones. Okay, um, and nowadays we can also go for percutaneous transhepatic cholangiography, PTC, percutaneous. So now this one is indicated when endoscopic cholangiography is not possible or it has failed. Okay, so then it can be done. And of course, like this PTC is done uh, to remove the impacted stones or to insert any stent, right? And then there is a lot of other investigations. We can go for angiography. I'm sure like all of you know what is that. And we can, nowadays there is something called as neo techniques, which are called as nuclear medicine scanning techniques, right? In which like we use some of the radioactive um, things, right? So of course, like these things can be done. Okay. By the way, these kind of things like this nuclear medicine scannings are done to check for metastasis in most of the patients who have cancers. Okay, and just to want to see like if the cancer is spread to any part of the body, uh, we can go for these things, right? So now, uh, guys, okay, just to talk about a little uh, about the topics, in general surgery, we had done one topic called as transplantation. Okay, so here we are not going to discuss like the transplantation in too much details. Or rather, we will not discuss at all, because we know when the transplantation is indicated. Like someone who has cirrhosis, someone who have a liver cancer, we go for transplantation. And liver transplantation is a very serious type of surgery. And uh, the point here is that. Like it is not done by one doctor, it is not the decision of one doctor, okay, we should go for a liver transplant surgery. Rather, it's a full team of doctors which take decisions. So uh, the thing to remember is, like, we are not going to discuss that, we are not going to talk about that. We had one lecture of transplantation, and I told you what is orthotopic transplantation and all this stuff, right? That is enough at this level. No one is going to ask you, like, how we do transplantation, what are the criteria, right? All this stuff. So we can do liver biopsies as well, uh, if we will talk about what kind of investigations we can do. Okay. So now, uh, what I'm going to start with is liver trauma. Okay. Like important topic from surgical point of view. So that's why I'm going to discuss that. And we have just 2 lectures on this liver. So I will try to cover as much as I can during this time, right? But my main emphasis, or you can say focus, is to cover 2 things, which is number one is the liver trauma, and number second is the uh, hepatocellular carcinoma, or you can say the primary tumors of the liver, right? So this is the thing. And to start with liver trauma, uh, like okay, now you will find a lot of details in the surgical books about liver trauma, right? You are not required to remember everything, you are not required to know each and everything, but what is required is, like, you must know the basics. Okay, and this tables, really, guys, don't waste your time in memorizing them. For example, there is Child-Pugh score, which is used in assessing the mortality in the liver conditions, but or uh, there are, you can say, other applications as well, but you are not required to
remember that, like how it scores. You must know, like, okay, what is that table and what is this used for? That's more than enough, okay? But you don't, like, no one is going to ask you in detail, like, what is this and how we use, what are the scores and all this stuff. So don't waste your time in memorizing useless stuff, okay? You must be good in basics, so that's more than enough, right? So talking about the liver trauma now, okay, you can see like some of the lacerations over here and the bleeding points, right? So liver injuries are nowadays common, right? Because of road traffic accidents, all the stuff. Though liver is well protected in the behind the ribs, you can say in the abdomen, but there are instances like when it started bleeding. And there are basically two type of main traumas which can occur to the liver. One is called as the blunt trauma, and the other one is penetrating trauma. So blunt trauma, like which can someone fall from second, third, fourth, fifth floor, or someone who is involved in a road traffic accident. What will happen to them is there will be a sudden deceleration injury, right? And when there is sudden deceleration injury, what is going to happen? That the liver will be lacerated or will start bleeding from inside, right? And the other thing is penetrating trauma. Of course, you know the gunshots, the stab wounds, okay, crush injuries. For example, someone's rib is fractured and the rib now is damaging the liver, right? Things like this. So these things can occur. So now anyone who is involved in the liver trauma, so what will happen? That okay, this is like the main thing which I have to discuss. Blunt trauma can occur in road traffic accident, fall from height, deceleration injuries, and uh, this is like the discussion of those things. Okay, there could be a direct blow to the liver and all the stuff. And what can happen? You can see over here in details. In deceleration injuries, most commonly sixth and seventh segments are can be fractured, and 5 and 8 of the right lobe. So this injury can lead to rupture of the right hepatic vein and significant bleeding. But whenever there is a direct blow on the right upper abdomen, for example in vehicular accident or by some assault, segment 4, 5 and 8 are the most commonly damaged. And there is a massive bleeding from the portal vein or hepatic vein. And also bile duct injury can be there, right? So penetrating injuries, of course, we don't know. It depends on. That's why surgeons are good in surface anatomy, because they know, like, if there is, like, what are the areas, what are the structures which are passing, and by the knowledge of that you can think of what kind of structures could have been damaged. Like you can say a stab injury may cause major bleeding from one of the three hepatic veins or the vena cava, and also from the portal vein or hepatic artery if it involves the ileum and all the things. So of course depends. So now the important thing over here is to uh, There is a table here, this one or this one, whatever you like, but they both are same. So American Association for the Surgery of Trauma, this is called as the liver organ injury scale. So this one is used. Now you don't have to remember that. See, like they talk about the description of the injury, they talk about the injury type, and they label it as grade 1, 2, 3, 4, 5, and 6. Okay, so you can see over here, like for example, if we read the grade 3, it is subcapsular tear greater than 50% surface area of the ruptured subcapsular or parenchymal hematoma, intraparenchymal hematoma greater than 10 centimeter or expanding, and greater than 3 centimeter parenchymal depth, right? Like if there is a hematoma, this is the thing. If there is laceration, this is the thing which we'll see. So we grade it as grade 3. Okay. Uh, Now you can see over here, for example, okay, I think we'll discuss that thing later, but see that this is the hematoma and this is the laceration, right? So if you'll see like the grade 5 and grade 6, like there is vascular injury. Grade 6 is hepatic avulsion. Okay. So of course, like it means serious bleeding. Okay, so guys, now this is where you have to do a lot of correlation. For example, you have to correlate this thing with emergency medicine. Okay. In emergency medicine, you are going to study how to take care of a trauma patient. What is advanced trauma life support? What is basic life support? Okay. So anyhow, remember this thing. Whenever we approach any patient, we go according to ABC: airway, breathing, and circulation. Taking care of their cervical spine. Okay. Uh, we conduct a primary survey, then we go for a secondary survey. I think I talk about in general surgery about these things, right? So now these are general things which we are going to do in any patients of trauma, not just liver, but of course we are going to discuss this thing here as well. Keep the patient warm. Hypothermia have very bad effects on coagulation and heart rhythm. Keep the room warm. Avoid hypothermia. You can give IV fluids which can be warmed. You can use warm blankets and all these things, right? Now, the important thing here now is to how we diagnose liver injury nowadays and how we used to diagnose the liver injury before. As I told you in the start, like, not much liver surgeries have taken place before because of just one thing. And that thing was simply because liver is a highly extensive vascularized organ, or you can say too much extensive blood supply is there. So it's very hard to stop the bleeding. Okay. And that's the reason uh, now the important thing is when liver have huge capacity to uh, bleed out. So simply we see the effects of the bleeding on the patient, like, okay, of course when someone lose a lot of blood, so they go into hemodynamic instability, their blood pressure goes down, their heart rates goes up, they become pale, they become cold and clammy skin, and all these things, right? So of course, like first of all, to diagnose, you would know was the scenario, how the injury occurred. You can then you will go for the examination. You will see around the liver area, like the lower chest or the upper abdomen, for any stab wounds, for any hematomas, for any lacerations. Okay, and I'm not saying like in liver injury, like we just pay attention to the liver, like rather we pay attention to the patient as a whole. So of course we start in emergencies with giving them IV fluids, right, to stabilize them, to you can say, overcome the effects of the blood loss, or you can say to provide them with as much fluids as we can, so that the patients will not go into hemodynamic instability, right? So simply, okay, the patient can present with hemothorax, can present with fracture of the ribs, and if the wound is a penetrating type of wound, then of course the story is different, right? So you know if I will talk in a very simple way, I would say that the surgeons, they have to decide, either we can manage this patient non-surgically, or either this patient needs a laparotomy right away, or you can say this patient needs to be explored to stop the ongoing blood loss, or to stop the development of any coagulopathy. Okay, so in that case, of course, the patient is taken to the operating room, and uh, nowadays, by the way, there is something called as FAST, that is focus assessment. Okay, so FAST is available in the emergencies, and uh, FAST is very quick procedure. Like, they can see any fluid around the liver, around the spleen, in around the bladder, around the pericardium. Like, these four focus areas can be checked very quickly within 5 to 7 minutes. Okay, and nowadays portable CT scans are also available, by the way. So if they found any free fluid, which means like the bleeding is going on, right? Before, like the thing which we used to do before, like this imagings were available in the market or in the hospitals, we do something called as DPL, diagnostic peritoneal lavage, in which they take a small fluid from the abdomen and see like if it contains the blood or not. Okay, so simply, now it completely depends. Like, either it's a penetrative type of trauma, or either it's non-penetrative, or you can say the blunt type of trauma. So you can say, like, the diagnosis of the liver injury, hemodynamically unstable patient. After primary survey and resuscitation, the patient may still be hemodynamically unstable. In these cases, it is necessary to immediately determine the possible cause of the continued shock state. This can be difficult in patients with multiple injuries involving many organ systems, right? And we can do a physical exam to check for peritoneal signs, penetrating injury, or increasing distension, right? And we can go for a focused abdominal sonography for trauma, or we can go for the diagnostic peritoneal lavage. This one is, of course, non-invasive, very fast. This one is slow and old. This one is new. But fast is not available everywhere. But in all the countries, developed countries, they do have fast in their emergencies, right? It's very quick. This is how they do the DPL, or diagnostic peritoneal lavage. They take the fluid and they check. Okay, and this is how they do a focused abdominal sonography for trauma. Okay, this must be here. This is called fast. You can see on YouTube a lot of videos about fast, how the machine looks like, and all this stuff, right? Very easy. And if the patient is hemodynamically stable, of course, we have time to go for a CT scan or ultrasound, right? So the story is simple. Hemodynamically unstable, you need something fast. So remember fast. Hemodynamically stable, yeah, there is time. You can go for some slower techniques, like you can go for CT scan, you can go for ultrasound. You want to check the structure of the liver, right? So these are the ones which are going to tell you about the structure of the liver. Simply. So now this is about CT scanning, about fast. You can see like there is a lot of photographs, which shows like, see, it is a lot of hemorrhage in the liver. You can see grade 1 injury, small posterior capsular, this one, tear. See this small tear you can see, right? This is grade 2 injury, posterior hepatic laceration you can see here, less than 3 centimeter deep, and there is a hemorrhage over here. Grade 2 injury, see there is a subcapsular hematoma. Grade 3 injury, hepatic laceration, greater than 3 centimeter in depth, the same table. And again, grade 3 injury, grade 4 injury, and grade 5 and grade 6. Now see in grade 6, there is deep hepatic laceration, and which means like hepatic veins and left hepatic veins, they are completely disrupted and huge, you can say, bleeding is going on, right? Grade 5 injury, they are showing over here. Anyhow, like this is CT scans and simply, now this is, see, this is the non-operative management of blunt liver injury. So first of all is hemodynamic stability. Go for CT scan, either it is grade 1 to 3 or grade 4 5 injury. So remember, see this thing very simply written. Anytime the patient is becoming unstable, directly to operation room. But if the patient is stable, see, we have to avoid surgery. So any patient who is stable, of course, you can go for ICU, keep on checking for jaundice, abdominal pain, unexplained signs of infection, go for CT scan again, check for all these things, okay, check for the sources, right? So the rule is very, very, very simple. If the patient is unstable, OR. If the patient is stable, observe them, okay? So, but the penetrating type of injuries, the story is different because that is completely, you can say, the dealing doctor is going to assess the, of course, after looking at the airways, breathing, and circulation, and giving 2 large bore cannulas and or like sending a call to the blood bank to arrange the blood for that patient, right? And so, like in the process, like when they are arranging the blood, so you can put the patient on some IV fluids, right? Then of course, like it depends on like uh, where is the penetrating injury, what structures can be involved, and all these things, right? Either exploration is needed or not. It is completely a decision of the doctor. So, okay, so see the difference between blunt trauma and, see, blunt hepatic injury transfers almost exclusively along the segments of the liver. Okay, this most likely occurs due to the strength of the fibrous covering around the portal triad, preventing injury from transecting these structures. However, the hepatic veins do not have similar fibrous structure and therefore having less resistance are the primary structure injured in blunt trauma. Whereas penetrating trauma, of course, it can disrupt both venous as well as the arterial structures, right? Now see, the management criteria for non-operative management is what? Hemodynamic stability should be there. Or you provide them with 1 to 2 liters of crystalloids and the patient is stable. Absence of other abdominal injuries during requiring laparotomy, preserved consciousness, absence of peritonism, and absence of ongoing bleeding on CT scan, conservative management, okay? Of course, the bleeding will stop on itself and then we will keep on checking, okay? The patient, okay, either they need any kind of intervention or not. Okay, close observation is needed, right? And the criteria for operative management is simply any patient who is hemodynamically unstable, or you have transfused the patient a lot, there are signs of peritonism, There is active arterial blush on CT scan, or there is penetrating trauma, right? So now, okay, we will discuss a little about operative management, and that's it. We are going to finish this topic, guys. Whenever you will decide to go for operative management for the patient, for example, the patient is hemodynamically unstable or they have the grades 4, 5, or 6 injuries. Of course, our main aim is to stop the bleeding, right? By perihepatic packing or manual compression. 4 P's of operative management. Looks very easy. Push, Pringle, plug, and pack. Now, what are they? Uh, Packing, as you know, prehepatic packing, like as the word is showing what it happens, like we are going to pack that area so that there should be pressure, and the pressure, due to pressure, the bleeding will stop, right? And that's what we do basically whenever we have any external bleeding going on, whenever we get injury, even whenever we have nosebleeds, what we do, we just compress that area, right? So, for example, you can see like the right costal margin is elevated. The pads are strategically placed over and around the bleeding site. Okay, and additional pads should be placed between the liver, diaphragm, and the anterior chest wall until the bleeding has been controlled. And sometimes more pads are required. Okay, so for example, this one, they have put a lot of pads. Okay, to stop the bleeding. Uh, okay, now, of course, like in the left liver, of course, because that area is some loose, so the specking doesn't help much in that area, right? And the bags are later on removed, right? So this is about packing of the liver, right? Pringle, pack, Pringle. Pringle maneuver, of course, as I told you, this one was described by a guy. His name was Pringle. And now, this is the Pringle maneuver. See, they put a clamp which occludes the hepatic pedicle, containing the portal vein, hepatic artery, and common bile duct. This is the one who described this one, okay? This is called as Pringle. So pack, Pringle, and then there was plug and pack. Push, Pringle, plug, and pack, right? So now, what is hepatography? So it's a suture which is used to approximate the laceration. Okay. For example, this one. See the laceration? So they put the sutures. This is called as hepatography. Sometimes we use mesh. Okay. And mesh is applied to that area to give some tension to create this tamponade effect. And one of the thing which can be done is hepatotomy. What is that? Of course, remove the area which is bleeding too much. Okay. So this thing can be done. So now these things can be done. Sometimes intrahepatic balloon tamponade is used nowadays. Of course, this is a new thing. Okay, so Foley's catheter can be used, Penrose drain can be used, Sengstaken Blackmore tube, which is used for esophageal bleeds, they can be used. Okay, so and the thing is simple, See, they put it, they inflate it so that it will cause pressure and it will stop the bleeding, right? And the last resort, limited to specialist centers, and it is used for extensive retrohepatic venous injuries, is total vascular exclusion. And it involves the clamping of the portal triad and infra and suprahepatic inferior vena cava, simply to stop all the blood supply, right? So simply, guys, most of the time a rooftop incision is used. Best to visualize the liver and the spleen. Okay, and then the story, like either you have to clamp, either you have to pack, either you have to perform Pringle maneuver, whatever, right? That thing can be done. So now the thing is that what are the post-op complications in this one? Post-operative hemorrhage can occur, like surgical hemorrhage, disseminated DIC can occur, and coagulopathies can occur. Sepsis and abscess formation can occur. Liver abscess. One more thing is, it is called as biloma. Like the bile can make a mass. Okay, collection of the bile can occur with or without infection, of course. That is called as biloma. And of course, like we can drain it, like by CT guided drainage can be done, or if it is sterile, then there's no infection, it reabsorbs itself. And some pretty simple non-operative management with intervention technique is preferred. Grade 4 and 5 and 6, 4 and 5 injuries in stable patients can also be managed conservatively. In surgical management, damage control surgery is preferred than definite procedures, right? And for inaccessible bleeding within a laceration, rapid finger fracture hepatotomy, Kelly crush hepatic transaction, direct suture of the ligation is preferred, and or perihepatic packing should be employed at an early stage, right? Formal anatomical resection carries a high morbidity. Hepatography discouraged due to complication of sepsis and bleeding. Okay, and liver failure is one of the complications as well. Fistula formation is one of the complications as well. So, uh, uh, rest like in the slide, you will find a lot of photographs. Okay, wait, maybe I can show you something. Okay, yes. I include these slides also, but I forget to talk about them, but it's okay. Okay. One of the technique which is used is called as packing by omentum. Okay. Like the lacerated side, they put a patch of the omentum and then they put sutures on that. Okay. This is manual compression of the major liver injury to stop the bleeding. Pringle's maneuver. Hepatotomy. Okay, so omental mobilization employed for liver packing. This is the tamponade effect, which can be done by Blackmore tube or Foley's tube, right? So all like there will be a lot of pictures. I think you can see yourself, right? So that's all, guys, about this liver trauma. I hope you understand, and I will see you in the next lecture.